Thank you, Mr. Chairman. The significance of positive margins and how to approach this problem has really been around for many years. There's a lot of information, some of it conflicting. What I really want to do is perhaps present some of the information and then an approach to this problem. We started off in liver surgery sort of way back into determining how much liver can we resect. There was a tendency to resect as large an amount as possible with wide margins in order to avoid recurrence. This has subsequently been sort of downgraded to segmental resection, and the approach now is parenchymal sparing non-anatomical resections. That really raises the issue of margins. Just what do we mean by margins? And I've got an outline there, ranging from 1 to 2 centimetres, less than 5, greater than 1 millimetre and less than 1 millimetre. The current acceptance is to achieve an R0 resection of greater than 1 millimetre. R1 margins are less than that. In fact, some people advocate it should be less than 0.1 of a millimetre. And then there's a concept of the vascular margin resection, R1, which really behaves similarly to R0. And this was the studies done by Ekberg and Blake Cady way back in the 50s and 60s, which showed that you needed a 1 centimetre resection margin in order to achieve oncological outcomes, favourable oncological outcomes. And it really got to the stage where if you couldn't do that, there was a contraindication to resection for liver mets. We really needed to have a look at that, because even though we've gone on from that to lower margins, the most recent systemic review and meta-analysis over 11,000 patients found that even though the R0 is the accepted stance, it was found that there was better oncological results in the greater than 1 centimetre margin compared to the others. So we've got to rethink, I think, a little bit about whether we shouldn't be achieving 1 centimetre. Why do we argue for margins when there's so many variables? There's tissue shrinkage of about 10% between the fresh and the treated tissue. Tissue preparation, standardised techniques and measurements vary from one centre to the other. And in fact, there's a lot of people advocating, and I'll come to that in a minute, advocating that the biggest lesion should be the one that's concentrated on. There's intra and inter-observer error amongst the pathologists. There's techniques of parenchymal dissection vary, whether you use the CUSA, whether you use energy devices, whether you use stapling. That really plays havoc with the margin. And tumour growth patterns also have an effect. So what we're really, when we're arguing for 1 millimetre and less than 1 millimetre margins, what are we doing really? The pathology, there were 2 studies, I think, which showed the extent of micrometastases and tumour involvement. There's the one on my right, on my left, which looked at mutant tumour DNA and found that there was really nothing beyond 4 millimetres from the tumour edge. The study by Kakudo showed that if you stick within 2 millimetres of the resection margin, then there's a less than 6% chance of recurrence. That's if you really believe that the resection margins are anatomical and technical failures rather than being a tumour biology problem. And this was the study which went really from the 10 millimetres to 5. This was an Italian study which showed that 5 millimetres was the cut-off point, and having a resection margin less than 5 was associated with increased risk of surgical margin and decreased survival. It was really the study from the Johns Hopkins which advocated that providing you get a clear resection margin, then the width of that resection margin is really not important. And he found that the positive R1 was associated with a decreased survival pattern, increased surgical margin recurrences, and also increased intrahepatic recurrences. And these two showed the R1 versus R0 in terms of recurrence at the surgical margin and intrahepatic, and also in terms of survival. It was clear that there was survival benefit with an R0 in most studies, except for the last study coming from France, which really showed that R1 equals R0 in terms of oncological outcomes. And this is a study which confirmed Tim Paulick's views from the Johns Hopkins, and which showed that a 2 centimetre margin is, a 1 millimetre margin was really led also to good oncological results. This is a study which looked at the margin being from the major tumour, from the largest tumour. Smallest tumours, large tumours, multiple tumours. But it was clear from the study that the margin from the largest tumour had the most oncological significance in predicting overall survival. So whether we should be doing that or not remains a question. Sub 1 millimetre resection margins. This was a study which looked at 1 millimetre or less resection margins versus R1, and it was shown quite clearly that the sub-millimetre resection margin really was the same as an R1 resection margin. What happens to the tumours that we detach from the vascular structures abutting the right hepatic vein, the middle hepatic vein? I think this study showed that an R1 from the vascular point of view is equivalent to R0 when compared to the parenchymal point of view. So tumours tumours near major venous structures that have to be removed will really have an outlook, even though if it's an R1, it'll have the same oncological resultants as an R0. And this shows R1 parenchyma versus the R vascular, and shows us an advantage which is equivalent to an R0. So in terms of the vascular impingement, detaching the tumour from the vascular structures really gives you still an R0 resection margin. So R1 resection margins are usually associated with bad prognostic tumours, bilobar, large, multiple. They're associated with increased surgical margin recurrences. They're associated with increased intrahepatic recurrences, and in most cases, they were associated with decreased survival data. Now, is it an anatomical exercise or a breakdown of surgical technique, or are we just looking at tumour biology? First of all, how do we predict R1 margins before we preoperatively? This was a study which looked at radiology versus pathology, and it showed that usually the pathology is underdone compared to the radiological. So a radiological margin is much higher than a pathological margin. This was a scoring system set up by the group from the UK, which looked at prediction of R1 resection margins and found that the factors which were involved were a non-anatomical resection, greater than 3 mets over 50, a bilobar disease rather than a unilobar, repeated resections after the primary hepatic resection, and abnormal liver function tests. And from that, they managed to have a predictive score. Let's look at tumour biology and what happens when, for example, there's a re-resection. At operation, R1 margin, you resect some normal and you achieve an R0. It makes very little difference to survival data. So correcting an R1 to R0 intraoperatively really doesn't give you any benefit, and this has been confirmed by a couple of studies. What about sensitivity to neoadjuvant chemotherapy? This group from France showed that the response to neoadjuvant chemotherapy has quite a marked outcome on the final oncological results. And found that if the response is complete, survival is in the region of 43%. If it's stabilised, it's still significant at about 30-odd%. Whereas if there's progressive of the tumour on neoadjuvant chemotherapy, the outcomes are fairly inferior. This was another study which looked at the effect of chemotherapy and whether tumour progression. This was shown that, for example, that all R1s versus R0s, there was a survival advantage. But if you looked at the tumours which had a major pathological response with an R1, then they actually were quite favourable. Whereas tumours that had a negative response, then the results were woeful. And that just goes on. There's groups now around the world which are advocating that R0 really gives you the same result as R1 in terms of using preoperative and perioperative chemotherapy. And this was the group from France again, which showed that an R0 and an R1 sort of basically gave good results, providing that you were aggressive in your outlook, there was re-resections and also chemotherapy. So the use of chemotherapy probably has brought the R1 back to the R0 stage. This was another study from the Mass General, which looked at 277 patients that underwent liver resection with neoadjuvant chemotherapy. 13% had margins less than 1 millimetre, 63% had post-resection chemotherapy. Positive margins had a negative impact on overall survival, but the use of chemotherapy had reversed that survival data. So the use of chemotherapy, both as a neoadjuvant to be able to predict the responses, and adjuvant chemotherapy really overcomes the effect of the resection margins. And the same with Tanaka's series, which again brought the R1, R0 together. And it was one of the few studies that also looked at hepatic arterial infusion. Further tumour biology comes from the KRAS, which as you all know is an indicator of tumour biology. And the KRAS wild type and the KRAS mutations, I think I'll just move on very quickly from that, but it has an effect. And in terms of margins, it has no real impact on the mutant KRAS, whereas the wild type KRAS had an inflector at about 5 millimetres and then moved on. So the biology of the tumour, sort of based on genotyping, also has an effect on tumour margins. I'd like to just sort of finish off with a survey which was done by over 270 surgeons from 52 countries on their experience of R1 resection. It was in the journals just recently. Over 90% reported a negative impact of R1 resection. 74% had developed surgical margin local recurrence. 31% had hepatic recurrence and 16% survival. 50% of that group accepted R1 as indications to resect rather than a contraindication. And 90%, over 90%, suggested the impact of R1 is modulated by chemotherapy. 50% of the group considered the risk of R1 resection as indication for neoadjuvant, and 80% accepted R1 resection for multiple myeloma disease that responded to chemotherapy. 40% modulated chemotherapy in the non-responders. 45% of the group, almost half, accepted vascular margin as R0, but most of the group really preferred right hepatic lobectomy for this group of patients. In the presence of multiple bilobar lesions, 27% considered local excision for this group. How do we approach R1 resection margins? First of all, always aim for an R0, and the wider the margin, the better. Predict and accept the high likelihood of R1, sort of based on imaging scores and scores. Use neoadjuvant chemotherapy to determine the responders. If no response, change the chemotherapy. Determine RAS and BRAF status with circulating tumour DNA, which can be done now quite accurately. Use the optimum operative approach, the use of intraoperative ultrasound techniques. Then continue on with adjuvant chemotherapy and re-resection of any resectable mets, and accept R1 vascular margins as R0. Thank you, and we'll see you all in Melbourne.